Welcome to This Explainer. Today, we're going to unpack a pretty fascinating medical mystery, and we're going to build it up from absolute first principles. We're looking at a disease that operates completely silently for decades before finally announcing itself in a totally predictable mechanical way. If you're the kind of person who likes understanding exactly why things happen in the human body, rather than just memorizing a laundry list of symptoms, you are absolutely going to love this. So let's dive right in.
Picture this scenario. A young woman walks into your clinic, and she's noticeably breathless. You examine her, and you hear it, a rumbling, low-pitched, mid-diastolic murmur. It's best heard with the bell of your stethoscope right over the apex of the heart, especially when you roll her onto her left side. You start asking about her medical history, specifically fishing for childhood illnesses. But, nobody in the room remembers her ever having a severe sore throat as a kid. She certainly doesn't remember one. So the question is, why does her valve remember? Well, somewhere, maybe 20 years ago, a strep throat infection happened. Her immune system fought it off, but actually, it fought just a little too aggressively. It left a tiny microscopic signature on that mitral valve. And that signature has been quietly and mechanically narrowing the valve ever since. Today, it's finally announced itself. This classic clinical presentation we just talked about, it's the absolute predictable mechanical endpoint of a disease with a decades-long silent phase.
Okay, let's jump into Section 1, the valve's silent history.
For the overwhelming majority of cases worldwide, mitral stenosis is rheumatic in origin. It all traces back to a Group A streptococcal throat infection. The mechanism here is called molecular mimicry. Basically, this happens when the antibodies your body raised to fight the bacterial antigen get kind of confused. They mistakenly cross-react with your own cardiac tissue, particularly the valve leaflets. It's literally a case of friendly fire. Let's look at how this builds over time. After that initial childhood strep infection, recurrent bouts of this inflammatory insult happen over the years. The valve narrows incredibly gradually. We're talking over a period of 10 to 20 years. And there are often absolutely no symptoms at all during this silent latency period until the orifice has narrowed substantially. This timeline perfectly explains why patients frequently have absolutely zero memory of the inciting illness by the time they show up in your clinic. The initial event is literally decades in the past.
Moving on to Section 2, anatomy of a fixed orifice. Physically, the valve isn't just getting a bit stiff. We see progressive fibrosis, thickening, and calcification. But the absolute key here is commissural fusion. The commissures are the points where the leaflets meet, and they get physically welded together at their edges. Underneath that, the chordae tendineae fuse and shorten too. Because the edges are welded shut, during diastole the valve just can't open fully. Instead, it domes down into the ventricle, looking kind of like a fish mouth or parachute. And this brilliantly illustrates the pathology because that doming appearance is a direct visual signature of commissural fusion that you can see clear as day in an echocardiogram. The crucial takeaway here is that the left atrium is now working against a fixed obstruction. Think about it. In a normal heart, there's basically no resistance when the valve opens, but physics dictates that to push the exact same volume of blood through this new, much smaller hole in the exact same amount of time, you absolutely must have a pressure gradient. That gradient is generated entirely by the left atrium, which now has to sustain much higher pressures just to force the blood through. Every single clinical feature we see next is a downstream consequence of this one mechanical fact. Right, which brings us to Section 3, the backward pressure wave. Let's trace the consequences of this elevated left atrial pressure step by step. Honestly, this sequence is the entire clinical picture. Step 1, the elevated left atrial pressure transmits backward into the pulmonary venous system. Step 2, this raises capillary wedge pressure, driving fluid right into the interstitium and alveoli. This is what causes exertional dyspnea, especially when heart rate or cardiac output goes up, like during exercise or pregnancy. Step 3, this sustained venous pressure causes reactive changes, producing pulmonary arterial hypertension. And finally, step 4, that high pressure places a chronic load on the right ventricle, eventually causing right heart failure. So you get peripheral edema, raised JVP, hepatomegaly. Notice how right-sided failure symptoms are really just the end product of a pressure wave that started all the way back on the left side.
Meanwhile, what's happening back at the left atrium itself? Well, it's dealing with chronic pressure and volume overload. This stretches the atrium out, causing atrial dilation. A dilated, stretched, fibrotic atrium is fundamentally arrhythmogenic, which is why atrial fibrillation is so incredibly common here, and it's often the presenting feature. Now, combine a dilated, fibrillating left atrium with stagnant blood flow, especially in the atrial appendage, and you have a classic textbook setup for thrombus formation and a very high embolic stroke risk.
All right, Section 4, Decoding the Physical Exam. Now, what's really interesting about this slide is that these physical exam findings are no longer just random facts to memorize. They are entirely logical consequences. That mid-diastolic rumble? That's just the turbulent, low-pressure sound of blood being forced through a narrow orifice. The loud S1, sustained left atrial pressure, keeps the valve open longer into systole, so when it finally does close, it slams shut forcefully. The opening snap, that's the abrupt halt of that parachute-like leaflet doming we talked about earlier. And the loud P2, that simply reflects the pulmonary hypertension we just traced through the lungs. Makes sense, right?
Here is a really crucial clinical pearl for you. Why does a shorter interval between S2 and the opening snap mean more severe stenosis? Well, because a more severely narrowed valve causes a much higher left atrial pressure. That massive pressure gradient forces the fused valve open much faster after S2. It's pure, elegant physics in action.
Section 5, Diagnosis and Severity Grading.
Transthoracic echocardiography is our go-to here. It's the primary diagnostic tool. It confirms the diagnosis, shows us the commissural fusion, and it grades the severity. It grades severity primarily through the mean transvalvular gradient in the mitral valve area. As a rule of thumb, severe mitral stenosis is generally defined by a valve area of 1.5 square centimeters or less.
Oh wait, there is a major pitfall you absolutely must be aware of when interpreting these echo results. Doppler-derived gradients are heavily dependent on heart rate. Tachycardia shortens the diastolic filling time. Because the blood has way less time to get through that narrow hole, the pressure gradient naturally spikes. This can make the stenosis look much more severe than it actually is. You have to always interpret the transvalvular gradient with the patient's heart rate in mind.
Section 6, the 2025 Valve Management Guidelines. Let's talk about how we fix this.
According to the 2025 ESC/ECTS guidelines for the management of valvular heart disease, the decision pathway is laid out beautifully. For symptomatic patients with clinically significant, typically moderate to severe, rheumatic mitral stenosis, the preferred intervention is percutaneous mitral commissurotomy, or PMC, provided the anatomy allows for it. This is a super clever catheter-based balloon procedure. Remember that commissural fusion we discussed? This balloon physically, mechanically splits those fused commissures apart and essentially reverses the core rheumatic lesion right then and there, without even needing open heart surgery. However, PMC definitely isn't for everyone. The echo has to score the valve morphology first to see if the patient is even a candidate. If the valve is heavily calcified, if it's immobile, or if it has significant subvalvular fusion, surgery is going to be required. Critically, because of the atrial stasis and that clot risk we discussed earlier, a transesophageal echo absolutely must be used before PMC, specifically to exclude a left atrial thrombus. If there's a clot or if the anatomy is just unsuitable, mitral valve surgery, like a repair or replacement, remains the necessary alternative. Now, while we're planning those definitive interventions, medical management is running right alongside them. We need rate control and anticoagulation for the atrial fibrillation because of that severe embolic risk. We'll use diuretics for volume overload to help relieve the exertional dyspnea. And, importantly, secondary rheumatic fever prophylaxis is used where indicated just to prevent any further valve damage from recurrent streptococcal exposure. So we've traced the entire chain, from a forgotten childhood strep infection to molecular mimicry to commissural fusion. That narrowed orifice forces the atrium to strain, pushing a massive pressure wave backward, causing pulmonary hypertension and right heart failure while dilating the atrium and risking a stroke. Literally every exam finding, symptom, and management decision traces back to that single narrowed orifice. So the next time you hear that rumbling murmur, you aren't just recognizing it, you're reconstructing the entire pathophysiology to make a critical, time-sensitive decision. Is a catheter or a scalpel the right way to fix the anatomy that started it all? That, my friends, is mitral stenosis, built from first principles. Thanks so much for joining me in this explainer.